Endocrine system drugs. The endocrine system. Endocrine refers to the internal secretion or hormones produced by the ductless gland that secretes directly into the bloodstream. Hormones are chemical messengers that have specialized functions in regulating the activity of the cells or organs. In other words, the endocrine system helps the body maintain homeostasis by transferring messages between systems and organs to keep both working efficiently. The endocrine system helps the body use energy, regulate temperature when the body sleeps, and assists in the reproductive organs by allowing the right amount of hormones to be excreted for reproduction. Medications are oftentimes used for the endocrine system to suppress or replace the hormones normally produced by the endocrine glands. Pituitary hormones. The pituitary gland is a small gland located at the base of the brain. It is called the master gland because it secretes hormones essential for body growth and development, and it regulates all other endocrine glands in the body. Hormones are grouped based on the lobe that they originate from in the pituitary gland. The anterior pituitary gland produces ACTH, FSH, LH, prolactin, and TSH. The posterior pituitary gland produces oxytocin and vasopressin. There are three major disorders or diseases that are affected by the pituitary gland. Hyperpituitarism, which results in giantism or acromegaly, is usually in the presence of a tumor and is treated with chemotherapy, radiation, or surgery. Hypopituitarism causes dwarfism and is often treated with somatotropin. Diabetes insipidus, not to be confused with diabetes mellitus. Diabetes insipidus is a disorder of the pituitary gland and is due to the underproduction of vasopressin or ADH, and we treat this with vasopressin itself, either in its natural or synthetic form. Adrenal corticosteroids. The adrenal gland sits on top of the kidneys. The adrenal gland secretes three different types of hormones: glucocorticoid, mineralocorticoids, and gonadal corticoids. Glucocorticoids increase blood sugar, stimulate protein catabolism, metabolizes fats, and decreases immunity and inflammatory response. An example of this group would be cortisone. Mineralocorticoids cause sodium and water retention. They increase blood pressure and blood volume. An example of this group would be aldosterone. Gonadal corticoids stimulate male sex organs and promotes development of the male. An example of this would be androgens. The adrenal glands secrete hormones called corticosteroids. It suppresses the immune system's response to infection and trauma. They relieve inflammation, reduce swelling, and suppress symptoms of acute conditions. So corticosteroids can be used to treat acute conditions, or they can be used as replacement therapy when the adrenal glands do not produce any of these hormones. Corticosteroids treat allergic reactions, rheumatoid arthritis or lupus, eczema and dermatitis, asthma or COPD, malignancies such as brain tumors, organ transplants to prevent graft rejection, and ulcerative colitis. When corticosteroids are prescribed, either they are prescribed for long-term use or they are prescribed for acute episodes. For acute episodes, oftentimes we are using dose packs, and some names of dose packs would be Medrol dose pack, prednisone pack, dex pack, and taper pack. And what this pack does is it facilitates dose tapering. And this is a picture of a dose pack. And the first dose, each line equals 1 day's worth of dose. So there are 6 days in this pack. The first day we want to take a loading dose, and in previous years and in the past, we have been instructed to take these pills throughout the day. So 2 in the morning, 1 at lunch, 1 at supper, and then 2 right before bed. However, research now shows that there is no benefit from taking the doses spread out throughout the day, that you can take these all at once and just make sure that you are consistent at what time of day you are taking this medication throughout the next 5 days. So the first day we will take 6 pills, second day 5, 4, 3, 2, and then 1. And the reason for dose tapering is it's important not to abruptly stop, because this can be harmful to the patient. The pituitary gland has been on vacation, so to speak, in producing that particular hormone. So it is important to slowly stimulate and get the pituitary gland back in the swing of things in producing those hormones. Addison's disease is when there's an undersecretion of glucocorticoids. And oftentimes we have to replace the cortisol that's needed. And some medications that we do this with are cortisone, hydrocortisone, or prednisone. And then sometimes with Addison's disease, we also have to replace the aldosterone. And when aldosterone needs to be replaced, we are typically prescribing fludrocortisone or Florinef. The opposite of Addison's disease is Cushing's disease, where we oversecrete the glucocorticoid. And treatment is based on what the cause is, but treatment can be anywhere from chemo, radiation, surgery, or metopyrone. Patient education on corticosteroids. Patients should never stop taking abruptly. They should be taken with food or milk, and this is mainly because of GI upset. Some of the side effects are edema, which is due to the increase in sodium within the body, which can then increase your blood pressure and cause hypertension if you are on long-term therapy. Delayed wound healing, GI upset, and osteoporosis. Hypoglycemia and hypokalemia are also very, very common. Corticosteroids should also not be taken, or a patient should not receive vaccines while taking them. They should also not take NSAIDs, as this is also an anti-inflammatory, and contraceptives. Thyroid function. The thyroid is responsible for regulating the rate of metabolism. When thyroid levels are low, the pituitary gland releases TSH. TSH then promotes the secretion of thyroid hormone T4 and T3. It is important that patients have adequate amounts of iodine within their system, as iodine is vital for the synthesis of both of these hormones. The thyroid also releases calcitonin, which is involved with calcium hemostasis. It inhibits bone reabsorption and the release of calcium into the blood, therefore making our bones stronger and healthier. Some of the disorders that the thyroid can have can be Graves' disease or Hashimoto's thyroiditis, which are both autoimmune disorders. Graves' disease causes hyperthyroidism or an overstimulation of the thyroid. Hashimoto's thyroiditis is an immune attack on the thyroid, which can cause hypothyroidism. Hypothyroidism can also cause creatinism in children, which results in dwarfism and retardation. So it's very important to have adequate TSH levels within the body, as this can be very harmful to the development and homeostasis and longevity of a person's life. Normal TSH serum levels are 0.5 to 4.0 milliliters per uroliter. Drugs for hypothyroidism are levothyroxine and Synthroid. Levothyroxine and Synthroid always come in micrograms or mcgs. Once a patient is placed on levothyroxine or thyroid, they will be titrated up to the dose that they need in order to have adequate functioning thyroid. When patients are started on this medication, they are then retested in 4 to 6 weeks after beginning this medication to see where their TSH levels are. It is important to instruct patients to take at the same time of day. We typically recommend patients take this 30 to 60 minutes prior to eating breakfast. It is said that if levothyroxine or Synthroid is taken with a meal, only 50% of the medication is then absorbed into the system. It is important to instruct patients to not change brands of medications or pharmacies in which they receive the medication from. Different brands, even generic or brand name, can have different fillers which can alter how the body absorbs the medication. It is also important that if a patient requires brand name, that on the prescriptions that are written out and sent to the pharmacy that says brand name medically necessary. And this is to ensure that they have consistent levels of TSH within their body and they are not having the yo-yo effect with their medication. Why are thyroid agents not used for weight reduction programs? Using thyroid agents can cause a decrease in the normal function of the thyroid and can also possibly cause life-threatening arrhythmias such as ventricular tachycardia or atrial fibrillation. So it's important that we do not use these in a weight reduction program. There are some other alternatives such as ephedrine and other weight loss programs that a patient can use. Levothyroxine and Synthroid. This is kind of a neat graph on how it takes a little bit for the medication to work. So when a dose is too low, patients will be bradycardia, lethargic, they will have constipation, excessive fatigue, and want to sleep excessively. When the patient starts medication, they will see a little bit of an increase in activity, but by the 6th day, they are feeling back to normal. However, it goes opposite, that if they miss the first day, if they miss one day of a dose, they are feeling huge effects. But if they miss 6 days in a row, they are going to feel irritable, palpitations, tachycardia, diarrhea, tremors, and insomnia. And this is when your thyroid is too high or hyperthyroidism. So you have a little bit of both here. So when a dose is too low, you have bradycardia. When you have too high, you have tachycardia. Antithyroid agents. So treatment for hyperthyroidism. Drugs are usually not long-term in this disease. The short-term drug is Tapazole or Methimazole. And the reason why they are short-term is that hyperthyroidism can be treated with radioactive iodine ablation therapy, and therefore patients do not need to be on this medication for a long period of time. The Tapazole prevents the thyroid storm, which is a thyroid toxic crisis, which is a huge and rapid influx of TSH and can be acute or life-threatening. Some of the symptoms of the thyroid storm are fever, hypertension, tachycardia, congestive heart failure, and shock. So the Tapazole protects from the thyroid storm and typically has less side effects. And what it's doing is it's blocking the iodine T3 and T4, the overly amount that will be produced due to the hyperthyroidism. You want to watch for peripheral neuropathy, fever, rash, pruritus, GI upset, and dizziness with this medication. Diabetes mellitus. So just a little overview of diabetes. Insulin, which is a hormone produced by the pancreas, acts to maintain blood glucose levels within normal limits. Insulin is essential for moving glucose into the cell for metabolism. And what happens is insulin attaches to this receptor and it tells the cell that it's okay to let glucose in. Diabetes mellitus is a chronic disorder due to insufficient production of insulin by the pancreas or cellular insulin resistance. Normal blood glucose levels are 70 to 100 milligrams per deciliter. Treatments. There are two different types. There is insulin, and then there are oral medications. Oral medications we will go over in a few more slides. But oral medications are for non-insulin dependent diabetics. Insulin is for dependent, or which means our type 1 diabetics, and sometimes our type 2 diabetics that are not responding to the oral medication regimens. Insulin must be administered parenterally because it is destroyed by the GI tract. The pharmacodynamics, or the way that the insulin is used by the body, is the insulin lowers blood glucose by promoting the use of glucose in the body's cells. There are 4 different types of action of insulin. There is rapid, and some examples of rapid are Aspart or Lispro, also called Novolog or Humalog. There is short, which is called regular or Humulin R or Novolin R. There's intermediate, which is called NPH, which stands for neutroprodamine hagedorn. You don't need to know that, but some students do ask me. And the other names for NPH are Humulin N or Novolin N. And then there is the long-acting, and some examples of this are Levemir, Lantus, and the newest one is Toujeo. So insulin types, there's different onset peaks and durations of different insulins. And different sources and different brand names will have a little bit different onsets, peaks, and durations. However, for the most part, they do fall in within the same range. So you will want to take a look at the insulin chart. So for rapid acting insulins are Lispro, the onset is 10 to 30 minutes. The peak is 1 to 2 hours, and the duration is 3 to 8 hours. And this insulin is what patients will take right before they eat, or if they are in a hyperglycemic crisis or need to reduce their blood glucose in a rather rapid time frame. Short-acting, 30 to 60 minutes is the onset, the peak is 1 to 5 hours, and the duration is 6 to 10. Intermediate, the onset is 1 to 3 hours, the peak is 6 to 12 hours, and the duration is 18 to 24 hours. And then our long-acting, typically patients will take this at night. However, it can be taken in the morning. And our long-acting is, the onset is 1 to 2 hours. There is no peak, and the duration can be up to 24 hours. Insulin. So insulin is always measured in units. It's not the only medication that is measured in units. However, insulin is only measured in units. It's never measured in milliliters or cc's, so always in units. And the most common is to have a 100-unit syringe. So this is an example of a 100-unit syringe I have here, and each dash equals 2 units. There are 50-unit syringes out there, and that's when each line would represent 1 unit. Insulin pens are becoming forever more popular, mainly due to their easy use. So you apply the needle at the end, and each time that you are administering the insulin as a patient, you would apply a new needle. And then the bottom here, then it twists to the dose that you need. So you see the numbers here, and this goes all the way up to 50 or 100, depends on the pen, as to how many units are in there. Some pens are less, some are more. There are several different types of pens, and anywhere ranging from our rapid-acting to our long-acting insulins. So it is important to educate patients that they need to prime their pens, and a lot of times patients will try and skip this as it wastes some of the insulin, about 2 units. You prime the pen to remove the air bubbles and to get a more accurate dosing, especially when you are just starting a brand new pen. And the reason why patients like these pens is that they don't necessarily have to be refrigerated anymore for certain types of pens. So they are easier to carry, they have easier storage requirements, so a lot of patients are requesting these. The only thing about them is some insurance companies do not like to cover them. However, insurance companies are becoming more and more accepting of the insulin pens and are covering them. So that is something that is changing as time goes on. Patient teaching, so administration. So our fastest absorption sites for our insulin are going to be the arm and the thigh. And mainly it's more rapid because we have movement within the muscles, and the subcutaneous tissue is closer to muscles that we move more readily. The most consistent absorption site, though, however, is the abdomen. Insulin is always given at a 90-degree angle, and it is important to instruct patients to rotate their injection sites. You can mix insulin, however, long-acting insulin cannot be mixed. Long-acting must always be given separate or by itself. Rapid and short-acting should always be drawn up first before an intermediate acting, and this is due to we don't want to contaminate the rapid-acting or short-acting with an intermediate acting. We don't want to delay the response in subsequent dosings. Expiration, insulins expire 30 days after they are opened. It is important that vials be refrigerated, and like I said, those insulin pens don't necessarily have to be refrigerated anymore. But we would encourage patients to read the manufacturer instructions once they receive the medication. Insulin can be given in a sliding scale. Typically, we give sliding scales to patients who are having a hard time. They're kind of like a yo-yo with their blood glucose levels. So what we do is we give them a range of what their blood glucose level was, and then they would correlate how many units they would give based off of that range. Typically, most patients are in the normal insulin sensitivity. Some patients are really sensitive, so they need a decreased dose, and that's what this left-hand column is. And then some are highly resistant, so they need an increased dose. They need more insulin in order to get that response. And typically we do not give geriatric patients that are just starting on insulin a sliding scale. It can be very confusing to some of our elderly patients, and it can also be confusing to some of our children who are doing this on their own. Oral diabetic medications. So there are 6 types. There's sulfonylureas, Alpha-Glucosidase Inhibitors, Biguanides, Incretin Therapies, Meglitinides, and Thiazolidinediones. Sulfonylureas lower glucose by stimulating the beta cells of the pancreas and release insulin. They inhibit the process of forming glucose from amino acids and fatty acids in the liver, and they also increase the number of insulin receptors to the target cells. First generation medications are commonly not used. However, second generations are more widely used, with the most common being glimepiride, glipizide, and glyburide. Alpha-Glucosidase Inhibitors, low blood sugar by delaying the digestion of carbs and absorption of carbs in the intestines. They can be used in combination with sulfonylureas. Drugs in this class are precose, and the side effects are GI issues and elevated liver enzymes. Biguanides act by reducing hepatic glucose production and increasing insulin sensitivity in muscle and fat cells. The main drug in this class is metformin or glucophage, and this is considered the first-line treatment. It should not be used in patients with a shellfish allergy. It is also contraindicated in patients receiving Riopec contrast dye. So this is that contrast dye that they use for some CT scans or heart catheterizations, those types of procedures. We would not want to give this medication prior to. A lot of physicians like metformin held 2 days prior to receiving any of this contrast dye. We also don't want to give this medication to a patient that has kidney or liver impairment. Incretin therapies, there are 2 categories: dipeptide peptidase 4 inhibitors. They increase the incretin hormone, which will increase the insulin secretion and decrease the glucagon secretion. The drug in this category, there is only one currently, and that's Januvia. Glucagon-like peptide 1 receptor agonists increase insulin production and secretion from the pancreas in response to increased glucose levels. And the drug in this category is Byetta. Meglitinides act to lower blood glucose levels by stimulating the release of insulin from the pancreas. Drugs in this category are Starlix and Pranon. Some side effects are GI upset. Initial weight gain and upper respiratory infections can happen. Thiazolidinediones decrease insulin resistance and increase insulin sensitivity by modifying several processes, with the end result being a decrease in hepatic glucogenesis and increased insulin-dependent muscle glucose uptake. Drugs in this class are pioglitazone or Actos, and Avandia, which is now off the market due to hepatotoxicity. So you will not see that medication being prescribed. So other drugs causing hyper or hypoglycemia. So there are a lot of other drug classifications that can cause these two conditions. So hypoglycemia is marked by symptoms of acute fatigue, irritability, weakness, sweating, blurred vision, palpitations, shaky, confused. In hyperglycemia, the symptoms are marked by polyuria, polydipsia, polyphagia, anorexia, fatigue, yeast infections, tingling of hands or feet or neuropathy, fruity breath, a decrease in blood pressure, sometimes an increase in pulse or tachycardic, and skin flushing. Some of the medications that we prescribe for other conditions that can cause hypoglycemia are alcohol, alpurinol, which is prescribed for gout, MAOIs, which is prescribed for depression, salicylates such as aspirin, and sulfonamides, which is a common classification in antibiotics. Hyperglycemia can be caused by calcium channel blockers, often used to treat hypertension, corticosteroids for inflammatory processes, isoniazid, which is used to treat tuberculosis, levothyroxine for thyroid disorders, oral contraceptives, Dilantin, which is common in seizures, patients with seizures, rifampin, which is a medication that is used for tuberculosis, and thiazide diuretics such as hydrochlorothiazide, which is used in patients with heart failure or hypertension. Patient education. So what do we tell our patients? Hypoglycemia prevention and symptoms. It's really important for patients to test themselves frequently. If they are on oral medications, testing themselves twice a day. If they are on insulin type therapy, they can test themselves up to 3 times a day in order for their insurance to pay for it. And not overdosing on the insulin amounts that they are taking or the medications that they are taking. A balanced diet, low in glycemic index, reporting nausea, vomiting, and infection, which can affect the blood glucose levels, taking medications at the same time of day every day, proper use of monitoring devices, using new needles every day, testing the right frequency throughout the day. Rotating injection sites is very important throughout the stomach. You can also use the back, the arms, or the legs. Check insulin expiration dates, so 30 days beyond the open date. Regular insulin should be colorless, and intermediate and long-acting will be a cloudy color. It is important to roll insulin vials but not shake them to help mix. Short-acting insulins should be drawn up first to avoid contamination and to ensure that the onset remains the same. Storage is 2 to 8 degrees Celsius or refrigerated, and insulin should avoid direct sunlight as this destroys the insulin. And proper disposal of needles. Needles should be disposed of in a sharps container or hard container and can be disposed of. There are centers where needles can be dropped off. Typically in our ERs in this area, we'll take sharps.